Welcome to On the Edge of Breakthrough, where hope meets innovation in the fight against cancer.
Hi, I'm Dr. Monty Pal. I'm a medical oncologist at City of Hope, and I'm really excited to bring to you On the Edge of Breakthrough, Voices of Cancer Research. We're going to be bringing some of our best researchers to the table to discuss exciting findings from their laboratories, from their research programs, and really get some great perspectives on what their plans are for the future. Well, I'm going to be especially careful on this podcast because I'm sitting across from my boss here, Dr. Ed Kim, who's our physician-in-chief at City of Hope, Orange County. He's done a ton to elevate that campus, and I happen to actually spend a day a week down at that campus, so I'm making sure today that I'm meeting all standards and expectations from you, boss man, okay?
We might have to do that in private discussion, Dr. Pal, but he's a great clinician. We love having him there.
Appreciate that. Ed, I have to tell you, it's just been amazing to see the transformation that's happened at City of Hope, Orange County for the past several years here, really ever since you took the helm. Tell us what attracted you to that job. I mean, you did phenomenal work at your previous institutions. What really pulled you over to us?
Well, number one, my wife wanted to live in Orange County, so I have to tell you the hardest gravitational pull was that. I didn't know what Orange County was, and now that I've been here for 4 years, I definitely know what it is. It's very nice. It's a very wonderful place to live, and it seems perfect for a place like City of Hope to set up shop. This center has really made its mark very quickly in the 6th largest county in the country, 3.3 million people, if you can believe it, in Orange County. I like building things. I seem to like that. And the challenge of putting a top cancer center in a new area of California, especially one that's very highly competitive, gets all of our juices flowing, right? And I don't have to do much. We've hired great people. Yourself, you spend a day a week down there. Just having Dr. Pal's name on our advertisings is good enough. I think that led to our first bump in our market awareness. And we've got really an all-star cast of faculty, nurses, clinicians. So my job is easy. I just have to make sure they behave themselves, but the rest of it, they do.
I actually first heard about you in the context of research, right? Translational research. You had the first article published in Cancer Discovery, which now is a very eminent journal in our field. But beyond that, I started to get to know you as this transformative leader who took your prowess first to the Carolinas to work with that group. Am I right?
Yeah, no, the research, we always like to think out of the box, right? I don't think we need to approach things in traditional ways. If we did, we'd have cancer solved and we'd be moving on to the next problem. Yeah. But I think these types of measures, and you've done the same thing during your research career, you have to think outside the box. You have to think about ways to speed up those cures to patients. And we did the same thing. So it was a great time I spent at my prior institution. I left a very prominent cancer center to go to Carolina's healthcare system, now Atrium Health, to build Levine Cancer Institute. I think all my close friends who could tell me the truth told me I lost my mind why I was doing this. I'd never had family there. We lived in Charlotte, which is a beautiful city. But the challenge was, could we build an academic hybrid center in a place that needed it, that we could bring research and treat people close to home? And so, in a few years, we had 26 sites across North and South Carolina. We connected a biospecimen repository with clinical trials and had almost 100 faculty members across these areas. We built a second phase 1 site. It was fun work. It was fun to develop something from scratch. And it was really gratifying to see how grateful the patients were that we brought this type of academic rigor to a place that really didn't have it before. People were traveling to other centers in the area. And I think I really enjoyed that and really made me think, okay, what's the next challenge?
One thing that I wanted to ask you about is this role that you've taken on as really a lead in our clinical trials office. It's a huge role, and it's one that really has been made even grander by this massive expansion that we've had across really the entire country. There's so much that goes into clinical trials, isn't there? There's the regulatory piece, there's the investment that we have in investigator training and so forth. How do you think through where to open studies? What is your approach towards that?
Monty, you bring up a point that everyone's been trying to solve, and that's the mousetrap, right?
Mm-hmm.
How do we deliver trials? How do we organize trials across a system? It's pretty basic if you have one center. You open your trials, they're available, everybody's there, the trials are available at that one center. We know the world doesn't exist in that way anymore.
Yep.
It's a very different world. We are a digital world. We are a distant world that's connected by electronic aspects. And so how can you scale that, right? That's the key. Can you take something, scale it, and still make it efficient? So we always try to look 5 years down the road. What would a good situation look like that's ideal for the patient and ideal for the investigator? And it's probably going to be different than what we're doing right now. That's the uncomfortableness of it. And sometimes we're not ready to hear what that change is. And so as I reimagine what City of Hope is now and what it's going to become, we have to use the clinical trial office as a way to predict what's going to happen for years to come. So I can tell you we're trying to lay down those foundations. Number one is that it's not practical to open every trial at every place. We just can't. The resources, the human capital, the paperwork will just, be overwhelming. However, how do we create access for these patients? I mean, that's really the key, and empower those frontline providers to know what's available. Well, one is that we make sure they're connected, and if patients have to travel a little distance to go to another site, that's the current model. And the first step is, again, that awareness, making sure the clinician knows, they can access the information quickly, they can tell their patient about it quickly, and they can get a resource from the trials office to help with the consent, the eligibility, all those things. But we can't scale that. I think the future state, and I haven't shared this broadly, but the future state of City of Hope and what we are laying down the foundations for are if Mr. Stone came tomorrow and said, we just acquired a site in South America. That is totally me making that up. I don't know any information, anything like that, but just saying, if that were to happen, the processes we are putting in right now would not flinch. In fact, we could easily add sites like South America. We could add the moon if we want. We just have to get around the drug transport. But the systems we're putting in place will allow us to do that. They will also allow us down the road to try and work toward a just-in-time situation so that if we get all the regulatory paperwork done, and I know I'm going into a lot of nauseating detail here, but this is important because if we can get to a point where any patient in our system could theoretically enter a trial, even when it's not open at their site, and do it within 2 weeks, that would be amazing. So consenting would be electronic. The providers would know the trial. They say, hey, this patient I found has a rare mutation. We don't have this trial open. They can't travel to Duarte, Orange County. How can I get them on the study? We could theoretically get the trial open within 2 weeks and let the patient get enrolled at that site. That's what I dream about.
I mean, just in time is really at the center of sort of pragmatism, isn't it? Because, you've got a patient sitting in front of you in the clinic who needs a therapy, maybe doesn't have that direct access to the clinical trial. I'm guessing that now, as a part of the City of Hope network, you could just, roll through the regulatory and get that study open overnight. Theoretically, that's at least possible, isn't it?
Yes, that's what we dream about. I think there is a path toward that. As someone who grew up in Terre Haute, Indiana, which, we didn't have a major medical center there. We had regional hospitals. Certainly, I didn't know anything about clinical trials and such. These are the communities that need it the most. And so we have those communities among our 40 sites across the country, and they need these the most. And so it's not going to happen tomorrow. It's not going to happen next month, but we are building a system that could get there.
You've always really sort of been a fan of pushing the status quo and making sure that we're taking things to the next level at City of Hope. What motivates you to do that?
It's interesting. I don't know. It goes back to my childhood. My parents were always like, well, don't make sure you don't participate in too many activities. And so they would say, make sure you just focus. If you, play the violin and study hard and play one sport. I remember I told them I was going to try out for the basketball team. They said, "Oh yeah, go ahead, no problem." And they knew because I'm a 5'8" stocky Asian kid in the middle of Indiana. There's no way that could happen, and I actually made the team. I also told them I was going to try out for it as a cheerleader, and they kind of almost chuckled and said, "Yeah, go ahead, yeah, no problem, you do that." And I did that. I don't know. I like hearing challenges. I think we all do, and part of, I believe, why we've been able to attract the staff in Orange County that we have is that the challenge is putting up a new cancer center, being pioneers. And I think it's that, again, in cancer, we're underdogs here, right? We're facing a very challenging disease. It wins a lot, but I think over the years, we've pushed back, and I think we're winning now. And cancer is scared. Yuman Fong will say, when I step in the operating room, that cancer's scared because they know what surgeon just walked into the door and is going to take care of it. So I think we have to have that mentality. We have to push the boundaries. And I challenge our folks, do not be content with the standard of care. Be a person who's going to be a pioneer who can redefine the standard of care. Because if you're practicing at the standard of care, then you are doing what we did yesterday. You're doing what we've always done. And that means you accept the way things are. And I don't accept the way things are. There are still too many people being diagnosed and dying of cancer. We need to fix that. And that's why we're super subspecialists, right? It is our accountability, responsibility to do that. And sometimes it's a message that's hard to remind yourself of. As you mentioned, Monty, when you're in the academics film and you've got to publish and you've got to write more studies and see all these patients and get your medical records done in time and do your billing and everything. But that's why we're here, right? Isn't that why we spend? That's why you're here for 18 years. I mean, look at the progress you by yourself and the field of, renal cell cancer and kidney cancers has changed the universe on how patients are. They're not dying anymore. They have too many options. Now you've created a situation where you're still needed because you got to help people sort out from all the therapies that you all have gotten approved over time. And so that's a great thing, but you can't be happy with that. You've got to figure out a way. What's the origin? How can you prevent it? How can we get more people to take these drugs now as an adjuvant or a pre-surgical drug instead of this is going to maintain you? So those are the challenges I find that are very rewarding. Maybe I like the underdog status because if you lose, people aren't going to say, "Oh, you should have won."
And remind me, Ed, you did that 7-year program at Northwestern, BS and MD combined, right? So it's really designed for folks who, as you alluded to, really know they want that career in medicine.
Go Cats.
Go Cats, there you go. And where was that transformative residency experience in between?
So I was at Baylor. So I just wanted to get, I don't know if I can say this on the air, but I wanted to get my butt kicked in residency, right? You got to learn. So I wanted to be at a place that had a private, a public, and a VA hospital. That was Baylor.
Okay.
Thrown straight in the trenches of the ER the first month I was there, Ben Taub Hospital, busiest trauma center in the country.
Right.
And then the first rotation I had was oncology. And then after that, I applied to MD Anderson. It was really funny. As I started telling people I was interested in oncology, they said, "Well, you're going to apply to MD Anderson?" And I said, "Who's that?" Because I didn't know anything about this field. And so it happened to be down the street.
Too funny.
I will say my parents were so traumatized when I was growing up in Terre Haute, and I matched in residency down in Texas.
Mm-hmm.
If you're not from anywhere south of the Mason-Dixon line, Texas is a foreign country, especially growing up in the Midwest. And couldn't you go to any one of the dozens of great centers up here? And it just happened to be Texas, and that I think it was fate because that's where I trained at a great place and was able to accomplish a lot of things.
I have to say, I thought it was a little wild that you decided to make this leap into administration and really sort of transforming some of these cancer centers. So give us a sense of what that career transition was like. I have a feeling that there are many in academics who might be tempted to make that leap, but are a little maybe too cautious in doing so.
Yeah, I think it's not one. People didn't understand when I left MD Anderson. They said, "Why would you do that? You're ruining your career." And I said, "No, I'm just pivoting my career." And I felt like I could build a team,
right?
That I could build new junior investigators because I can't think of myself as the savior for lung cancer and that I'm going to have to be the one doing everything. That is not a team mentality. And so I wanted to be more in the coach role and let the players perform. So we groomed new leaders, new experts. And so, I've always felt like if I could create twice as many than when I left, then I've done a good thing for the field, for patients, for everything. I haven't run a drug development study in 10 years, and I'm proud to say that because I've brought them in. I've helped people formulate ideas. I've helped people guide people in their careers, and they've been able to do it. So now we're passing it forward. And it's really, I think, something we have to face in academics is really paying attention to our young folks, allowing them the freedom to grow as researchers because they are our future. And then hopefully they will pass that forward and further. I'm a strong believer in that. No one will have to compete with me to get a drug or a trial. I will help them get it. And so that's how I felt. I think my style has been very servant leadership. I didn't know what that meant until I got my M.B.A. So, that was about 5 or 6 years ago. But that's the way my behavior is. I enjoy setting up systems where people can succeed, and I take a lot of joy in people succeeding.
Right. I mean, clearly, you're not a 9-to-5er. You've got to be sort of putting in long hours. You're here with me doing this podcast on your vacation. I just want the audience to know that.
This is a joyous vacation to be with you, Dr. Pal. So trust me, it's a pleasure.
Thank you. I appreciate that. I really do. But tell me, how do you sort of achieve that work-life balance, or do you?
I like spending time with my kids. My daughter and I do a lot of things together, as you know, and same with my son. We'll do things together, and he went to us to see Wicked for the first time last night, so he enjoyed that. But I think work-life balance is you have to love what you're doing, you have to have a passion for what you're doing, but you have to make sure that your family is one of those passions. And so, the time gets allocated based on how busy you are at certain times of the year and such, but you got to make sure you always have time for them. And I think that's the same with the people that I've recruited, I've hired. I always ask consistently, do you feel like I'm not accessible? Because they always say you're so busy. They said, no, if you email me or text me, you always answer right away. Same goes with patients. If they contact me, do I answer? Do I respond? So that's just a habit of being responsive and giving the attention where it needs. And I think that's how you can truly achieve that balance, is that you got to make sure not ignore the family, not ignore your patients, not ignore your staff or the people who you're trying to mentor. And that can take a lot of time. So you have to have good hobbies.
You did give me a little bit of a segue there when talking about stuff you do with your son and daughter to bring this up. You and your daughter share one thing in common. You're
Swift
both
Nation, baby.
There you go, Taylor Swift fans. You beat me to it. So tell us about this. You were actually on Good Morning America talking about your Swiftiness. Am I right?
No. So she was interviewed by Today Show. We've both been fans of Taylor Swift. Again, just the music part. We go to concerts together. So we've enjoyed that. We went to 2 of the Eras Tour concerts. She posted a TikTok that went viral. She's not a TikToker, but decided she wanted to do this, and crazy. She was on Ryan Seacrest radio. It was written up. It was about the daddy-daughter relationship early on, and Taylor Swift, how they do that. And it sort of trended, which was cool.
I love that. And for all the listeners, we're actually going to put a little link to that in the tagline below this podcast.
Oh,
so
good.
You can click there and find that. I'm going to sort of segue into a different sort of general topic that, I think is, highly salient to what you do from day to day, and that is, ensuring that our faculty remain invigorated about their jobs, right? And we talk about this existential crisis that we have in academic medicine. This is a big deal, big problem in my mind. People are leaving academic medicine in droves. And again, I like the fact that you've blurred the distinction a little bit about what academic medicine is versus, what I think many of us have traditionally envisioned as being community practice. So I'm going to let go of that term. How do we keep people excited and motivated to keep coming back to the office every day?
I think medicine is a calling. If you believe that your mission in life is to support patients, to help patients, to make their lives better, whatever field of medicine or whatever field you have in general, there's plenty of other areas, social work, there's People who just constantly want to improve people's lives, even in government, then I think that's where your passion has to be. So that's number one. Number two is that, yes, then the realities of your job and your day-to-day come in. And I think it's our job as leaders to be very transparent with our folks. Look, we're all smart folks. We understand that there's not one person or one entity that can control anything and fix anything. I can't change the way we interact with payers. I can't change the EHR, but we can do what we can to help support them. Because if we all believe in the same mission of trying to help people, help patients, then we're all going to try to help each other to achieve those goals, right? If we're all working toward the same goal of helping the patient, it's not a turf war. It's not about who should do what duty. It's, look, if you're busy, I'll pick you up. If I'm busy, please pick me up. And I think that's what medicine has to be, because there are a lot of forces out there that make it very challenging to deliver the care that we want. And I think people have to feel like they're supported, like they are helping people. Nothing better than getting satisfaction or gratification from a grateful patient. I mean, you know this. You have so many long-term survivors in your practice, Monty, and they're grateful, and I think that energizes you, right? It validates what you're doing. It shows that you're doing good in the world, and making advances. And so I think that's something that is really hard to find in many professions.
But at City of Hope, we're uniquely positioned in large part thanks to this amazing base of supporters, right? We just, in my mind, have the best supporters that are out there who really kind of get behind projects, who are really emphatic about their personal goals and seeing that sort of translated into science and into research. And on that note, you've actually played a part in securing one of the largest gifts we've ever gotten at City of Hope to support integrative oncology. So I wonder if you could maybe tell us a little bit about that and where those projects are headed.
Same principle. I went back to my original dossier that I wrote up when I was first hired, because, it's easy to, change history and think. And integrative oncology was one of the top three. I wanted to bring that to City of Hope. I wanted to bring it to Orange County. And, it's not a huge money-making service. It's, it's something that some people call alternative therapy or, other types of nomenclature. I felt it's very important because it really looks at, again, outside the box ways that really are more inside the box than we know it. When we think of, certain regimens for, acute promyelocytic leukemia, those started as vitamins and natural compounds that all of a sudden became westernized.
Yeah.
So there are things that we do. And, Taxol comes from a bark of a plant. So let's not discount what plants and different natural substances do. I had to get Rich Lee to buy in. He's the key. That guy is a world's expert in integrative oncology. I am not. He was the right person to lead a program. We recruited him successfully. We put a program around him with acupuncture, massage therapy, very small, but at least it's a starting point. So he could see the results. In the meantime, we were able to find a very generous family who believed in the vision of integrative oncology, believed in the mission of City of Hope, and we were very fortunate to get a $100 million donation to support a center. It's the Chung Family Center for Integrative Oncology, and Rich Lee is thriving. We just finished our first year in the center. It exceeded all expectations. In addition to the initial $10 million we got, we were able to raise an additional $4 to $5 million on top of it to support more research projects, more services, and we've brought in experts from across the country who want to be part of this program. And because of our footprint, our 40-plus sites, California, Chicago, Atlanta, Phoenix, we're going to have a national system integrative program. I don't even want to call it national. Again, we talked about earlier, this could be an international program. I want us to be the best place in the world, at least in this country, for integrative oncology. And we have to drive that through clinical trials. We have to drive that through training the next generation of integrative oncologists and really get people to understand that a blend of Eastern and Western techniques is the best for a patient. You can go out to workout places, there's yoga, there's meditation. This is very much in the norm. You play music. You have a very talented band in your house. I get to watch them on YouTube and on your social media. Music therapy is a real thing. It calms people. Why do you think the athletes are all wearing their headphones before they're getting ready to perform? Because music calms people. Art calms people. It's why we have art galleries. Why don't we have smell galleries? Well, we go to restaurants because the smell is so good. We go to candles and soap stores because the smell is so good. These are all the senses that we can help people calm and heal that we are underutilizing in hardcore medicine.
So you said integrative oncology was one of your top scientific priorities. What are the others?
Screening and prevention.
Okay.
And then precision medicine, including the BMT and cellular therapies. And that's why at Lennar, we've started our auto BMT program. We're going to do a 7th patient pretty soon. We will start our cellular therapy program after the new year. This has to be done. City of Hope is the best place in the country to get a transplant, to get cellular therapies. Our pioneers like Steve Foreman have done an amazing job developing these. We're going to be implementing these programs in our campuses across the country, Lennar first in Orange County, and then Chicago, Atlanta, Phoenix. We will also have those there. City of Hope will be able to help 90 million people within 90 minutes with our geography.
One of the stories I'll share with you is I heard recently that Liz Buddy, who is a terrific CAR T-cell investigator, actually flew out to the Chicago site from our Duarte site to oversee one of the first CAR T-cell infusions over there. I mean, that level of sort of camaraderie around sites, I think, is really sort of unprecedented. I mean, it raises the bar a little bit for me in terms of what I need to do to get my program mobilized across the country, but definitely food for thought, wouldn't you say?
Well, you all in GU have done a great job of being welcoming to our other new parts of our family, and I commend you for that. We are ready to bring trials to all these locations from you all because we want to make sure that we are a unified system, and I think that's the spirit of City of Hope, is wanting to embrace others, whether they're part of our family or they're part of our patient family.
This program is titled On the Edge of Breakthrough. So, Ed, what does that mean to you?
Well, I think it means a lot of different connotations. Easily we talk about cancer therapeutics and how we can cure cancer. I look at it as breakthroughs being also through how innovative we are. Our program around Access Hope, our Cancer Patient Bill of Rights through legislation requiring people to have the right to find an NCI-designated center to help their care. We know the survivals are better that way. Other breakthroughs are how we are setting up a national system in clinical trial. These are all different types of breakthroughs at City of Hope. I view breakthroughs in multiple planes, in the therapeutics, in the laboratory, in policy, in how we're trying to prevent cancer. We know that the younger people are getting cancer at alarming rates under the age of 50. We need to solve that. It's our job as one of the top cancer centers in the country to take that on.
That makes perfect sense. And it's so on point with something that I've seen evolve as one of your major areas of career focus, ensuring accessibility of these discoveries, right? I think of the work that you've done with this group, Friends of Cancer Research, which is a group that I'm quite intrigued by, right? And the whole intent of the group, as I understand it, is really to make sure that every patient who deserves a clinical trial has access to one, right? So part of that effort is really understanding eligibility for clinical trials and broadening the scope of that. Maybe you can tell me about other things that Friends of Cancer Research and you have done together.
Yeah, Friends of Cancer Research, I currently serve on the board. It's, Ellen Siegel, Marlene Malik, they are the leaders of this. They've shaped it through policy. So trying to make sure that the appropriate bills and support for research is there from DC onward, that they're looking at interesting projects to work with the regulatory bodies, the FDA, the NCI. They've run studies to look at diagnostic testing with blood-based testing and accuracy. They also have a project now of looking at digital path and trying to figure out how many times is a pathology report changed based on one center versus another? I mean, we know that happens when we sit at the big centers and we review path. And our experts who only read that type of cancer say, this is not lung cancer, this is something else. It's alarming how much that changes. 20 to 30% is what the data tells you at these major centers. So trying to figure out how we can better serve patients in those types of projects is great. And the project that I worked very extensively with them, they did honor it as one of their top 25 projects of their 25 years in existence, was eligibility criteria. I've written hundreds, as you have, clinical trials. And what is exhausting is the number of eligibility criteria that a patient has to go through to qualify for a study. If there are 40 of them, they all have to check the boxes. They're eligible. One no means they're out of the study. And I hate that. I think that's wrong. I think in this modern day and age where we have so many therapeutics that are safer, easier to give, and have such a higher level of effectiveness, it's almost unethical not to allow a patient to be treated on a study, especially with that many criteria. So I've always been pushing for less is more, 20, 15, 10. I think we could challenge ourselves and do that. I also think that patients should not be penalized if they have a more important eligibility criteria than another. You've run a lot of drug studies that require these biomarkers. If we find that rare biomarker in a patient's tumor, why would we use that as an equal eligibility criteria as if your liver function tests were slightly off? There are definitely big differences between the two. And I think we should actually have a scaled version, a composite score. A biomarker should be 10 out of 10 in the importance level, clinical importance. Anemia, 7.5 hemoglobin, you might rank a 3 or a 2. That's how I think we should do eligibility. It doesn't take away from safety.
I like that. I really like that. And I saved one of my toughest questions for last.
Excellent.
Yeah. So, you mentioned some of your areas of research priority as being integrative oncology, certainly precision medicine. I think that's a huge focus. Prevention and screening is the one that strikes me as being a bit unusual for City of Hope. And I'll tell you why. Having been here for 18 years, I'm used to seeing that patient with aggressive metastatic disease, that patient who walks in the door with a diagnosis already sort of firmly in hand. I've never thought of us as being a place with a focus on prevention and screening. So how do we kind of change that mindset?
Yeah, we first start with services and research. We're not here to take business away from folks, but our job as a top 5 cancer center is to lead the way to help get rid of cancer. And that includes finding ways to prevent or decrease your chances of getting cancer. We've opened up through philanthropic efforts a pancreatic cancer screening study. People are like, well, there's no standard for pancreatic cancer screening. And I said, no kidding. That's why we have to do it. We don't just sit by with the status quo. Just because someone said it doesn't exist, that's an opportunity for us to create a pathway to an existence. We're also doing stomach cancer screening. Again, especially in the AAPI population, if you live in Asia, you're getting an endoscopy to screen for gastric cancer, stomach cancer. If you move to the United States next year, you don't get it. I don't understand what changed. I guess maybe the time zone and maybe the geography. I don't get it. We're also going to launch a thyroid cancer screening program.
Oh, interesting.
And again, we've got the protocol written. It's all approved. I'm just waiting for the right philanthropic organization to help us out there, but we're ready to go. We need to find ways to help people avoid hearing those words, you are diagnosed with cancer. And the only way we can do that is start preventing it. And we need to start looking in that direction.
Beautifully said. Beautifully said. And we've really run the whole gamut today. We've covered, this amazing leadership that you've had over our emerging efforts in Orange County. Talked about your vision for City of Hope as it expands across the entire country, frankly, clinical trial efforts in that regard. Thank you so much for joining us. Learned so much today.
I enjoyed it, Monty. Always great to spend time with you, even on my vacation.
This podcast was produced in partnership with Amaze Media Labs.